We will have one case presentation right after the lectures. And before I go to the main session, I will request you to have a look on chat box. আপনারা চ্যাট বক্সে দেখতে পারেন একটা লিংক শেয়ার করা হয়েছে যেটাতে বলা হয়েছে আমরা এই কোর্সটি শুরুর প্রথমে একটি সার্ভে নিয়েছিলাম এবং কোর্সটি এখন শেষ পর্যায়ে আমরা আরেকটি সার্ভে নিচ্ছি সুতরাং আপনারা এটাতে অংশগ্রহণ করবেন লিংকটি এখানেই দেওয়া হয়েছে Today our first speaker Dr. Hunter Gorninger he will talk about end of life care and he is the palliative care director in Washington DC USA and Hunter you will get 20 minutes for this lecture our colleague Saiduzzaman will bell the ring just when you have 1 minute over to you Dr. Hunter thank you
Okay, can people hear me adequately?
Yes, we can.
Great. Okay. Good morning, everyone. Well, good morning in the United States. Good morning. Good evening in Bangladesh. I am going to go off camera so that so you can see my slides well, and hopefully the transmission is good. I'm going to share my screen. And hopefully that will work as well. Can you see my screen? Can you see slides? What looks like slides? Great. Here we go. So for the next 20 minutes or so, I'm going to give an introduction to care of our patients and support for their families during the last hours of life. Oops, there we go. So after this session, I'm hoping that people will be able to do 3 things. I'm hoping that you will be able to describe physical findings that are associated with what is called and what I will refer to as a syndrome of imminent death. I'll describe that. I hope that you will be able to name common symptoms associated with the dying process. And I hope that you will be able to describe the role of multidisciplinary palliative care and family support at the end of life. 3 different things, and we'll cover each of those. So here is an example case that we can frame our discussion around. Imagine a 56-year-old woman with metastatic breast cancer who is no longer receiving any anti-cancer therapies. She is at home and she lives with her family, who consists of her husband, her brother, and her 3 children. And her family describes to you her declining physical function and activities in recent weeks. Today, they describe her as bedbound, having minimal food or water intake, and occasionally hallucinating. Often she is moaning, and that's hard for them to witness, and it's hard for them to know what to do. So here are some questions to frame our discussion today. What exactly is happening here to her physiologically, and what is happening to the family unit? What can we tell the patient if she's able to communicate with us? And what are we able to tell her family? What symptoms should we look for? And how can the entire palliative care team assist? So I really encourage everyone all the time in these cases to be thinking in that multimodal, multidisciplinary way about what are some different sources of suffering that are taking place here. So part 1, we're going to talk about the syndrome of imminent death. The syndrome of imminent death, that's a term that's often used in clinical literature to describe what is happening physiologically during the dying process. And here are some ways to frame that syndrome of imminent death. We might consider a time course, an early part, a middle part, and a late part. Early on in this process, patients are often bedbound. They may have less food and water intake, and they may have cognitive changes. Perhaps they're sleeping more, Perhaps they have episodes of delirium, and that may be an agitated delirium where they're very activated, or it may be a hypoactive delirium where they are very drowsy and not very interactive. A middle part might just be more of this, more decline in their mental status to the point where the patient is really not communicating at all, really not moving at all or taking anything by mouth at all. And then a very late stage, which often includes what are sometimes termed in lay terms a death rattle, which is really a term for excessive oral secretions that are pooled in the mouth and oropharynx, a coma, or even more decreased cognition and interaction, a fever, change in respiratory patterns, and changes in extremity appearance and temperature. So this is just a way to try to frame this syndrome. It does not mean that it always takes place this way or always proceeds in a linear fashion, but at least it helps us to understand what to look for and how we can counsel and support families and attend to sources of suffering. So in the time course, there's quite a bit of variability along this time course. And one way to consider this variability might be to think about what was the underlying status or function of the patient before reaching this syndrome of imminent death. And there's a spectrum here, there's variability. But for example, someone who is more cachectic, who has not been eating, who has lost a lot of weight, perhaps has a progressive illness, perhaps has a progressive functional decline from a longer time course of an underlying illness such as cancer or heart failure or pulmonary disease. Those patients may have a shorter syndrome of imminent death because their bodies are already have progressed to significant deterioration. Someone who is more well-nourished, perhaps someone who was previously healthy and then succumbed to a trauma or an acute illness that is leading to death, that time course might take longer because physiologically that person has more physiologic reserves to begin with. And again, this is just to try to frame the way that we understand what's happening with an individual patient and counsel patients and families. So I might ask, where might our patient be on this time spectrum? And I'll see if anyone has a thought, and if not, we'll just move on. I think that given this patient's underlying metastatic breast cancer, and I noted that she had a progressive functional decline over a period of weeks, she probably has a much shorter time before death. I would often use a range such as hours to a couple of days if the family asked or would like to know what I thought in terms of a time course. And these are common family concerns when this is happening. Depending on the family, depending on the individual, our families may never have seen someone die before. And so a lot of support and education is a good part of what we do. And these are common questions that families have. And we'll talk about some ways, some examples of how to respond to them. Is our loved one in pain? How would we know if our loved one is in pain if he or she cannot tell us? Is our loved one starving to death? What should we expect? How will we know that time is very short? Should I stay by the bedside? Should we stay by the bedside? Can he or she hear what we're saying in the room, talking to them? And what do we do after death? So these are really common family concerns across geographies and across cultures. So that was part one. I'm going to move on to talk a little more about common management strategies. And to start with that, I'm going to go back to the questions I just shared with you. I won't read them again, but what I'd like to do is just think together for a couple of minutes about how we might begin to provide some responses to families who are asking these important questions. I'm going to share with you some examples here. I am not suggesting that these are the only responses that could be offered, or that these are necessarily the best responses for every patient. These are just some examples to think about, and it might be helpful to, at least to have some examples as you do more of this work with patients and families. You will also find the language and the communication that feels right to you, and that feels right for each individual situation. But let's give this a try. Is our loved one in pain? How would we know? It's really important to educate and reassure families that part of our job as palliative care clinicians is to work very hard to prevent this, or if we observe any pain or physical distress, that we will work very hard to manage it and improve it. And depending on the case, that may be an opportunity to intervene and do some good pain management. It may be an opportunity to educate about how we assess for pain in patients who are not able to tell us whether they have pain or not, and how we can manage that pain. Is our loved one starving to death? A common response that I use is no, that this is the change in appetite, the change in eating and drinking is a normal process of the body shutting down. Starvation is an experience of the body wanting to eat, wanting to drink, and not being able to do so. This is a different process that's happening physiologically, and it is normal for the body not to demonstrate interest in, or ability to eat or drink. And that's really important to help educate and reassure families. What should we expect? How will we know that time is very short? A good response, initial response might be that part of our job is to help prepare you for what may come next in the next hours or days. I gave you an example with this patient of my own estimated prognosis based on what information we have. And you can certainly ask families if they want to hear that information and share it in a way that is supportive and reassuring to them that we will be there to support them and assure the patient's comfort through those final hours or days. Should I stay by the bedside? Should we stay by the bedside? I often will respond, if it's important to you to be present at the bedside, then yes, your loved one should never be left alone in the home. I am often reminding families that because patients at this stage are not able to care for themselves and advocate for themselves, it is very important that an adult is with the patient, at least in the same home all the time. But for many patients, or excuse me, for many families, it's important just to be by the bedside, to be present. And I really encourage families, when they signal that that is important to them, to take advantage of that opportunity to spend as much time by the bedside as they wish to. Can our loved one hear what we are saying? It is really impossible for us to know that for sure. There are some medical studies that suggest that patients at these final stages can still hear many things around them, certainly familiar voices. It's impossible to know for sure for every patient, but I always recommend that families talk to their loved ones as much as they wish. Perhaps they hear, and certainly perhaps they hear and hear the familiar voices of their family. And what do we do after death? It's always helpful, depending on the geography and the culture, to remember that death is not in and of itself an emergency, especially when it's a death that we are planning for and supporting families through. That our job as a palliative care team is to make a plan with a family for what to do after their loved one dies. And that's part of the work that we do. We don't have time today to go through all of the different management strategies for addressing all of these common concerns. I wish we did. but just at least to have a framework to start how to respond to these questions, these common questions, I thought would be helpful as a starting point today. And then finally, how do we involve the palliative care team? Well, those of you who have heard me teach before know that I am very fond of the referring to the multiple modalities of suffering that patients and families experience in advanced illness and in the dying process. And that is still true, of course, in the last hours of life. Patients have physical symptoms. We've touched on some of those today. And it's also important to attend to the family's distress around this, educating the family about signs of distress and creating a medical plan to manage symptoms. I use the term deprescribing to remind us that at the end of life, medications and interventions, therapies that patients have been taking to manage their chronic progressive illnesses are usually not needed or not helpful in the last hours of life. And this is an opportunity to help stop those medications and reassure and educate families that the patients do not need to continue taking some of those medications. And you can determine that together as part of a team. Psychologically, certainly we've touched on patient distress and family distress, support to family, especially to children. And some of our faculty are experts in pediatric palliative care and working with children around grief and bereavement. That is very important too. Spiritually, through this course, we've talked about existential distress and the importance of understanding and addressing the patient's spiritual framework and the family's spiritual framework. And this is very important in the last hours of life. So part of our multidisciplinary palliative plan is to support patients and families spiritually as well. And then finally, socially, as our case outlines, this is the matriarch of the family. This is the mother of 3 children who is dying, and this will break down the family unit. There may be tremendous social implications of her death, financial implications of her death, and these are important for us to be aware of and to support families to the best of our ability. So some strategies that may be helpful based on some of the framework that I just shared with you, confirming treatment goals and making adjustments that are relevant to the situation. I talked about deprescribing, stopping medications that are not relevant to comfort is a very important part of our palliative plan. And you may have a phrase that really helps to align these treatment goals with the clinical situation at hand and with expressed goals from the patient or from the family. I often will use a phrase like, we want to do everything that promotes our goal of comfort, and we want to stop interventions that are not helping that goal. If they help our patient to be more comfortable in these final hours and days, we want to do that if it's possible. If it is not helping our patient to be comfortable, then we should probably stop those interventions. It's important to communicate clearly what's going on. You may say something like, this patient is actively dying, or I do not think that your loved one will live very long. It is important, and part of our communication skills are to understand the best way to communicate with family members, but to communicate clearly so that they understand what we are seeing physiologically, that the patient's life is ending and the patient will die soon. It's really important to provide excellent mouth care and skin care. These are things that certainly in many hospital settings, this might be neglected or forgotten. It's very, very important to continue to provide mouth care to help the lips and the mouth to stay moist. That's easy to do even if the patient isn't eating and drinking. And skin care as well. We've had some excellent teaching by others on wound care and skin care. And for some family members who really want to be able to actively do something to care for their loved one, these are some wonderful ways for family members, if they wish to do that as well. We've talked a lot about providing frequent counseling and support to families, reassurance and education, and then treating symptoms and signs of distress as they arise. That is our core palliative skill set. And I really encourage, I know that many of our participants are physicians and nurses, and certainly I know that our physicians and nurses who are participating here are keeping in mind these signs of distress and symptoms. I also encourage other clinicians who are not physicians or nurses to be at least familiar with the symptoms. It can be very helpful if you are visiting a patient and you hear or witness some example of distress, to be able to communicate back to your team, hey, I think that we need to do some pain assessment again. I think that they may need a physician or nurse assessment and possibly an intervention. That can be really helpful to extend the reach of our team. Common symptoms during the last days of life. Here are 8 common symptoms. Some patients have all of these symptoms. Some of them may have just a few. But I think it's really important as you build your awareness and skill set. As you build your awareness and it's important as you build your skill set for assessing and managing symptoms to be able to address these particular symptoms for patients who are close to the end of life. Your assessment should include assessment for these and having a plan ready and being sure to educate the family, since the family are usually the people who are at the bedside most of the time. So in summary, this has been an overview of the last hours of life. I hope that you have a better sense of recognizing the syndrome of imminent death, that you have a sense about how interdisciplinary or multidisciplinary communication and support to the family is absolutely critical at this critical time in the patient's life and the family's experience, and that you have at least the beginnings of a sense of how to recognize and to plan and communicate and to manage common symptoms in the last hours of life. It's a lot that we covered in a short period of time, and I hope that at least this is a helpful introduction, and I look forward to our discussion. Thank you very much.
Thank you, Dr. Hunter. You're exactly on time. And I was going through one course on end-of-life care and found that death preparation, even the artificial nutrition could be artificial nutrition could be not that good for a patient. And that was the point I never knew before I started working in palliative care. We will have discussion on your lecture, but now we will go for our second speaker, Laila, who is a senior staff nurse working at Palliative Medicine Department in BSMMU in Dhaka, Bangladesh. Over to you, Laila Tulapa.
Thank you, Dr. Tasneem. Now I share my screen first. Can you see my slides?
Yes.
Yeah, we can.
Thank you. Hello, everyone. My name is Laila. I'm senior staff nurse from Department of Palliative Medicine, BSMMU. Today, I'm gonna present on nursing issues in palliative care. So the nursing issues in palliative care, I want to share with you some of the topics that is related to helpful for palliative care patients. That bedbound patient care, it is very important, and how to transferring the patient from wheelchair to bed or bed to wheelchair, skin care, of the patients and some slides of wound care, mouth care, stomach care, lymphedema care, final hours, and self-care. So at first, I am going to start with bed bath. So bed bath is very important for the patient who are continuously in for bed bound patient actually will need bed bath every day or every other day. For if bed bath is not wanted by the patient, then must wash face and hands and perianal area every day. And as it is very hard or difficult one person to maintain the bed bath for the patient, so it is good or may need to be done by one or two people. Some supplies needed for the bed bath that are towel and small cloth, water, soap, clean clothing for after bath, and plastic sheet. Then I'm going to transferring the patient. So it is very usual and common nursing issues in our patients, for our patients actually, because we have to transfer many times in a day. So at first we have to explain to patient what I am gonna do and transfer from bed to chair or chair to bed. Then bend knees as caregiver and hold arm of the patient. And after that, put one leg in between the patient's leg, grab hold of trouser or salwar to use when lifting. And then when secure the wheelchair is most important. Sometimes we are forgetting that thing, so some accident may occur. And then we should position patient near side of bed and lift patient by bending knees and shift to the chair. And after finally, we put patient in a comfortable position chair or bed. Then I'm going to share some general skin care and at the end of life care, and for the bedbound patient also, general skin care is very important. Skin care should be done or repositioning the patient every 2 hours so that prevention of pressure sore has taken, and we should be aware of pressure risk areas like feet, ankles, bone areas. Proper moving patients in bed should be maintained, and wash daily the patients with mild soap and sometimes warm water. After that, washing moisturizing cream must be maintained, and change linen daily. If wet or soiled, change immediately, and we use pneumatic bed if needed. This is a picture of pneumatic bed. Use pneumatic bed or air mattress if the patient is unconscious or paralyzed patient, if there is any advanced age or advanced stage of disease and already has and pressure ulcer. We can use soft pillows to support pressure areas, and we should be in mind that not directly under the heel, because it can make the heel pressure. It can continuously pressure the heel area then, and will turn to a wound. So always remember that not directly under the heel. When we shifting a patient in bed, draw sheet reduces the friction and shear. So we can use a draw sheet to maintain the patient's skin integrity. If we drag the patient, then the skin will tear. Skin of palliative care patients is very fragile. So use of a draw sheet is a important thing. This is the pictures of the pressure ulcer points. We should daily check of the areas like heels, coccyx area, and back of head and ears, shoulder, elbow, hip, and inner knees. If ulcer is present, document date and stage. We know that there are 4 stages of pressure ulcer. The stage 1, in the stage 1, the skin may be very painful, but there is no breaks or tears of skin. It may be red, and the skin may feel warm to touch, and the skin will be firmer or softer than the area around it. In the stage 2, the skin will be open, and when we touch, it is tender and painful, broken the skin or may blister. In the stage 3, the tissue under the skin is involved and it will be painful, and bad smell, necrosis may occur, and fat may also show. And stage 4, the wound may be very deep, and sometimes it extends to muscle, tendon, and bone, and very painful, very difficult to heal. So we should check the areas, pressure ulcer areas, to identify the pressure ulcer at the earlier stage. Then the cleaning wounds is very important in palliative care also. Clean, and the principles of wound care are assess and document daily, and change dressing daily in most cases, and also prevent pain by giving SOS pain medication before wound dressing. For adult, we use usually morphine, and for children, we use midazolam. Clean daily with normal saline or cooled boiled water, and use irrigation with syringe, no needle. Avoid wiping with gauze as this causes mechanical damage to new tissue. Sometimes shedding of gauze fibers into the wound remain there and will delay healing also. And after the cleaning with normal saline, apply Vaseline soaked gauze directly on the wound and cover with dry gauze or cloth, and secure the dressing using micropore. There is a controversy of use of antiseptics in the pressure ulcer or malignant wound. So antiseptics are not recommended here because no chlorhexidine, iodine, betadine, or hydrogen peroxide. Do not use all this because this damage the new skin cells which are healing the wound. These antiseptics doesn't kill bacteria, yes, but they also kill the skin cells. If we clean the dressing or wound regularly, then there is no chance to grow bacteria. So our priority is to help to grow new skin cells. Don't worry about the bacteria. There are some wound issues, like many wounds have pain, foul smelling, bleeding, and maggots. For pain, you prevent pain by pre-treating with morphine. We can use this 30 minutes before dressing change, and for children we can use midazolam. For foul smelling, we use metronidazole, crush tablet, and we use also we can use the green tea bags or any other like at first we use a tablet we can use injection metronidazole in the wound, or metronidazole tablet crushed tablet over the wound also, and green tea bag also use. for the bleeding, we pressure the ulcer 10 minutes for 10 minutes, and after that, if bleeding is not stopped, then we can use tranexamic acid or injection tranexamic acid or tablet sucralfate crust, or if there is no improve, then we can use adrenaline also. For maggot, we can prevent by keeping wound clean and covered. We can use fresh raw meat, fish, chicken, beef, applied directly on the wound. And we can use turpentine also, that will draw out maggots, but do not touch turpentine to skin. Dressing should be changed frequently if there is any maggot, and it is recommended to dressing 3 times a day if there is any maggot. Oral hygiene is very important. Oral hygiene is very important for palliative care patients and at the end of life care. So mouth care should be done 2 or 3 times a day. We can help patient who can do the brushing the teeth. We can encourage them, and if they cannot do that, so we can help them to gargle with salt or sodium bicarbonate. We can make it by 1 cup of water, 1 teaspoonful salt or sodium bicarbonate. Lubricant of lips is very useful for the patients who are using the oxygen regularly, and this tend to may have to use more often due to the dry mouth. So mouth care we should done after taking of food every time. If there is any candidiasis like white patches in the mouth, tongue, or esophagus, treat with nystatin and should not eat, drink right after for 20 or 30 minutes, to be given every 6 hours regularly. And we can advise people to that they can swallow nystatin to treat esophagus. The next is the stomach care. So stomach care is also very common and important care to improve the quality of life of patients. Like, for example, colostomy care and tracheostomy care is very common in palliative care. Colostomy is common with the colon cancer patient. So it is actually intestinal waste. When the intestinal waste leaves the body through the stomach, a colostomy is created when the healthy inch of the colon is sutured into an abdominal opening. So there may be temporary or permanent colostomy. The output of the colostomy is collected in a pouch attached to the abdomen over the stomach. So the pouch can be emptied when it is 1/3 to 1/2 full, passed, and reused. There are many types of pouches like 1 piece and 2 piece. So the other nursing issues are lymphedema care. It is common, very common for breast cancer patient, or say cervix patient, or when there is a lymph node involvement and metastasis occur, and obstruction of the collection of obstruction of the lymph node. Lymphedema occur, it is the collection of lymph in the interstitial space due to decreased lymphatic drainage or failure of lymphatic system. So it can happen for the cancer itself, or metastasis, or the treatment of cancer, like for any radiotherapy of the lymph node, or for the obstruction actually. So in the lymphedema, the main four cornerstone of management: the skin care, compression, masses, and exercise. Skin care actually for the prevention of infection, further infection, so that patient can have a good control over lymph node. And compression is must. It is according to stages of lymphedema, which compression we can give, and there is some massage and exercise for this management. And it will be based when we can do the four cornerstone of management at one time. So at the final hours and end of life, it is very crucial for the people of terminal illness, for the patient or the family members also. So we can encourage family to spend time with the patient, and when the terminal restlessness approaching, we can give quiet environment, so no outside stimulation or noise. We can give quiet music in the background according to the culture of the patients, and reduce lights over bed. We can give medications for the restlessness, and this is the stage when we can we need the multidisciplinary team approach. And for the last hours, when noisy breathing and secretion approaching secretion occur, then breathing that can be difficult for family to hear emotionally, we can reposition patient on the left side for secretions to go into the stomach. It is the semi-lying position, and sometimes we can use atropine drops for the secretions. We avoid suctioning, as it is not the problem of the patient, because patients family this secretion or noisy breathing is the most disturbing for the family. So we should keep just repositioning the patient and keep the lip moist. Self-care is very important in palliative care setting, because there are some stress in palliative care. The causes of stress in palliative care is that we can feel that care we are doing is we are not doing a good job, and sometimes people death it is very difficult for us sometimes, and we have communication difficulties many more times, lack of support, and sometimes work overload, and it is the main thing that we can go burnout. And burnout is the state when physical, emotional, and mental exhaustion occur, and it is caused by long-term involvement in emotionally demanding situation. So ways to there are some ways to help with burnout, and here we call it self-care, that we can do the better care to the patient. Use of relaxation techniques, deep breathing, and it is helpful sometimes, and take time off on a regular basis. Be aware that we can't do everything every time, and sometimes when we feel difficult situation and a difficult situation, we can spend time each week discussing patient with a colleague and organize some social activities, so we can do our self-care properly. Thank you. Thank you for hearing me. I'm stopped here.
Thanks, Laila Tulapa, for delivering again excellent practical lecture to us. We will have discussion on both lectures now for next 10 to 15 minutes. And before we go for that, I will request you to respond because we want this one to be a very interactive learning platform. Many of we are Bangla speakers, and just to let you know, we have Bengali faculty members, those who are watching the chat box. Even you can unmute yourself and ask your question, comments, even the experiences. আপনারা যারা এখানটায় দুটো লেকচার শুনেছেন, আমি অনুরোধ করব আপনারা যেন বাংলায় রেসপন্ড করতে চাইলে করতে পারেন। আপনারা চ্যাট বক্সে কোনো প্রশ্ন, আপনাদের কোনো অভিজ্ঞতা অথবা আপনাদের কোনো ব্যক্তিগত অভিজ্ঞতা অথবা আপনারা কিছু বলতে চাচ্ছেন এরকম কিছু থেকে থাকলে প্লিজ এখানটায় লিখতে পারেন অথবা আনমিউট করে বলতে পারেন। আমরা সামনের 10 থেকে 15 মিনিট এই দুটো লেকচার নিয়ে আলোচনা করব এবং নির্দ্বিধায় বলতে পারেন। Dr. Catherine, I could see you wrote about tranexamic acid in the chat box, and thankfully we got 2 responses from 2 different persons. And could you please explain that how we can use tranexamic acid topically for everyone? Hopefully I will translate it in Bangla for others. Thank you.
Hi, thank you, Tasneem. So sometimes we need to use tranexamic acid systemically. So for some patients, you may have large, for example, GI bleeding or hemoptysis. And in this case, you would use the tranexamic acid tablets or injection, as you either by mouth or by injection. But when you have, for example, a malignant wound that is oozing, which is bleeding, so sort of surface bleeding, we can use the tranexamic acid tablets or a vial for injection topically on the wound itself. So when you're doing the dressing change and you've cleaned the wound, you can crush the tranexamic acid tablet and just apply it directly over the surface of the wound. And it's very effective actually at stopping the wound bleeding. And then the other option would be to use the vial of tranexamic acid onto gauze. And then you put that gauze on top of the bleeding site on the wound. And it's very effective to stop bleeding. And this can be done very easily by the nursing staff doing the wounds, or we can teach family members to do this at home. And you can maintain hemostasis of the wound by using this.
Thank you, Dr. Catherine. আপনারা যারা শুনতে পেলেন, আমার মনে হয় আপনারা অনেকেই এটি ইতিমধ্যে প্র্যাকটিস করেছেন। তারপরও আমি বাংলায় আরেকবার বলে দিচ্ছি। আমরা যখন কোনো এখানে একটা উদাহরণ ব্যবহার করা হয়েছে, সেটা হচ্ছে ক্যান্সার উন্ডের কথা বলা হয়েছে, যেটা থেকে উজিং ব্লিডিং হচ্ছে। এরকম অবস্থায় আপনারা ড্রেসিংটা শেষ করার পরে আপনারা একটা করতে পারেন, ট্রানেক্সামিক অ্যাসিড ট্যাবলেটটাকে সরাসরি ভেঙে ওখানে দিয়ে দিতে পারেন গুঁড়ো করে। আরেকটা হতে পারে আপনারা ভায়াল থেকে এই ট্রানেক্সামিক অ্যাসিডটি যদি আপনারা গজে নেন, তারপর গজ দিয়ে এই সেই উন্ডের জায়গায় আপনারা অ্যাপ্লাই করতে পারেন। এই দুটো মেথডেই করা যেতে পারে। আমরা কিন্তু প্র্যাকটিক্যালি দেখেছি যে আমরা ইনজেকশন অথবা ট্যাবলেট হিসেবে মুখে খাওয়ানো হয় এই ব্লিডিং কন্ট্রোল করার জন্য। এটাও আরেকটা মেথড, টপিক্যালি আপনি কিভাবে ব্যবহার করতে পারেন সেই সম্পর্কে। আপনাদের কারো আর কোনো কিছু জানতে চাওয়ার না থাকলে আমরা আমাদের পরবর্তী ধাপে চলে যাচ্ছি, যেটি হচ্ছে একটি কেস প্রেজেন্টেশন। ডক্টর Catherine Richardson, who is a palliative care specialist working with MSF, she will do the case presentation today. Over to you, Dr. Catherine.
Thank you, Tasneem. Can you see my slides?
Yes.
Thank you. So really this case is not going to give you any new information, but we're going to go over some of the information that we've already shared. And we have time because we haven't had a lot of questions yet for discussion. So I'm going to invite you to use the knowledge you've just heard, that you heard in the videos we shared, in the presentations you've just seen, just to answer the questions again. So it's information that you've already heard today, and I just want you to apply it to this case, and we can have discussion around these points. So we'll discuss the case of a man called Saiful, who is 54 years old, and he is living in the camps with his family. And he has a diagnosis of lung cancer. He has been a smoker for his life, and he has COPD. And he's very cachectic, so he's lost a lot of weight. And you go to see him in his family, in the family home within the camp, and you find that he's very tired and very weak. He's had a gradual decline in his mobility over the past 2 weeks. And at the time you see him, he's been on bed rest now. He's not got out of bed for the last week. The family share that he's now sleeping for longer periods during the day, and he's only really waking up for a few hours each day. The day before you go to see him, he'd been drinking small amounts, but now he's coughing when he takes sips of fluid. His speech is confused, and he's asking to see relatives who have died. So does this sound familiar? Have you all seen patients with this sort of presentation? Feel free to unmute or type in the chat box.
আমরা কি এরকম রোগী দেখেছি? যদি দেখে থাকি আপনারা চ্যাট বক্সে লিখবেন প্লিজ।
So we can think about, so as the doctor and nurse caring for Saiful, we can think about what is his likely prognosis, okay? And why do you think the prognosis is that? So again, please do type in the chat box and say how long you think this man may have left of his life and why you think that might be the case. So Samuel, Islam, you've shared that you do, this sounds familiar presentation. So we've seen patients like this. So does anyone want to have an estimation of what his prognosis might be? If you think back to Dr. Hunter's lecture and the guidance he gave you on how to best guess the prognosis, would anyone like to have a guess? Okay, so you're all very quiet, so I will answer the question. But don't worry, you won't get it. I'm sure you won't get it wrong. So do feel confident to unmute and share. But my best guess at his prognosis would be, as Dr. Hunter was sharing on the patient on the left side, it'd likely be hours to a short number of days. Okay, and if we think about why this is, oh, hold on, we've got some comments in the chat. Hours to days. Thank you, Tasneem. Yes. So Dr. Tasneem agrees with me. So why do we think this? Because the decline has been going on over the past weeks and he's now changing day by day. Okay, so sometimes when you see changes in your patient status week by week, they may have a number of weeks left and no one knows how many. When you see changes in the patient status day by day, it might be an indication that your patient has a number of days left, although we don't know how many. And similarly, when you're seeing changes hour by hour, it's an indication the patient may have some number of hours left, although of course we don't know how many. And Saiful has been on a progressive decline in his mobility and on his fatigue over the last 2 weeks. He's now sleeping for much of the day, so he's entering to the stage where he's almost in a coma, and now he's unable to take any sips of fluid by mouth, and that's changed from yesterday. So things are changing, and it's likely he has at most a small number of days left of his life. And We don't always know for sure, but we share with the family members our very best estimate of how much time might be left. So we've talked, Dr. Hunter shared with us which symptoms Saiful may experience in the last days of his life, and we can think about how we might treat them. So over the course, we've been looking at symptom management and how to treat different symptoms. We had the lecture on pain management, we had lecture on managing breathlessness and nausea. So let's have a think about which symptoms Saiful may have at this time and how we might manage them. Does anyone want to have a go at that? You can either write in the chat or you can unmute yourself. So Saiful could have a range of symptoms. The range of symptoms that Dr. Hunter was sharing are common at end of life, but given the diagnosis of a lung cancer, there's a high chance he may have pain. Now, if Saiful didn't have pain prior to the last days of life, he may well not have pain at this point, but usually pain will persist at end of life if the person had pain earlier on in the course of the disease. So Saiful may have pain, so we ought to ask about that and make sure his pain is being managed. And if you remember, we use the WHO analgesic ladder to manage pain. Often patients with end-stage lung cancer, they often have chest pain, not always, or they may have pain from the sites of METs if they've got bone METs or brain METs. So we think about where their pain is, and what's the most likely cause, and that will help to determine how to best treat it. So we also need to think about other symptoms, and he already had a diagnosis of COPD and he has lung cancer, so he may well be breathless. And at this stage in the illness, it doesn't matter too much the cause of the breathlessness, okay? So it may be from the lung cancer itself and the COPD, it may be from an effusion, it may be from superimposed infection, it may be from anemia if he's got bone mets. So lots of different causes for breathlessness for patients with advanced disease. But in last hours and days of life, we're much more interested in, as Dr. Hunter said, maintaining comfort and not investigating to try to treat, because we know that's an extra burden for the patients and it's not going to change the course of this condition. So we're looking to treat the symptoms. And for breathlessness, we use morphine. So Saiful may actually struggle with oral morphine now, but we can use it sublingually and ask him to hold it under his tongue. If he's in an inpatient setting, you could think about using subcutaneous injections of morphine. But morphine is a very useful drug because we can use it for pain and breathlessness. So we can have two indications for this medication for Saiful. So if you remember in the history, Saiful was having some confused speech, and he was starting to talk to relatives who had already died. And so he may have a level of delirium, and he may benefit from antipsychotic medications such as haloperidol for management of that. We know that delirium can be worse if pain is untreated. So sometimes we treat pain, and if he's disturbed by his confusion or he's a risk to himself because of his confusion or agitation, then we would also be looking to treat that. So we'd be thinking about an antipsychotic medication, or actually at this stage, it's probably more beneficial to think about using more sedative medication like benzodiazepines. So we can use those crushed, something like diazepam or midazolam injectable if you have it. And we just tell the family that it may make him more sleepy, but it will help with his agitation, his restlessness. So we just explain what the medications are for and how they'll help. And as Dr. Hunter and Laila both mentioned, secretions are very common in the last hours of life, and we can dry the secretions up using usually a hyoscine patch is the easiest thing to use in the home setting. So how do we share with the family that Saiful is now dying? Okay, so Dr. Hunter already touched on this in his lecture, and I think the key really is to remind you that, again, this is delivering difficult or bad news. And we have had our lecture on communication skills, and we use the spikes model to deliver difficult news. So again, you're giving family news that is going to change for the worse their outlook for the future, because they're going to learn their loved one is dying. So you can use the same model, but it's, as Dr. Hunter said, it's absolutely critical that we use language which is clear, is simple, and is understood. So the key message is to tell the family that Saiful is now dying, because by knowing that information, they can plan to be there, to be at the bedside, and make sure that things that need to happen can happen, and they're aware of the fact he's dying. They're not going to, if you plan this part properly, the communication, but also the care planning, you're not going to, the family are not going to bring Saiful rushing into hospital in the middle of the night, only for him to die in hospital. They can choose where he will be. They can choose to keep him at home where he's likely to be more comfortable. So it's very important the family understand that Saiful is now dying, and we discuss what the plan of care is moving forward, how they would like him and how he would like to be cared for given the situation that he is in. So I see something more on the chat. Okay, so yes, death rattle, exactly. That was the chest secretions we were talking about. And as Hunter and Laila have pointed out, the positioning can be very helpful. So again, this is a recap of some of the things that Dr. Hunter shared in his lecture. So what may the family be concerned about at this time? And common things that the family are concerned about are common for different patients. So we hear the same questions often again with family. And as Dr. Hunter shared, you become more confident in answering these questions, the more patients you care for at end of life, and you start to have these conversations with the family members. So often family might be concerned or ask about why Saiful is very weak and tired, and you can respond by normalizing this. So at this stage in the illness, when people are approaching the end of their life, it's very normal for them to be very, very weak and to not have very much energy. It's very normal for them to sleep for large parts of the day. And then you can explain what to expect next. So, and this will progress. This will likely be that in the coming days, Saiful will be sleeping all of the time. So he will the time where he's awake will likely get shorter, and the periods where he's awake get further apart until the time where he doesn't wake up anymore or respond to voice. So we spoke a little bit about oral intake, and this is often a big concern for families, especially when food is a very important part of the culture. And Dr. Hunter explained very nicely how he responds to this question for patients and their families. And the key is really that the person's body does not need food or water at this stage. When people are dying, they have no appetite, and actually trying to give them their loved one drinks when they're coughing in response can actually make them in a worse condition, because it can cause them to aspirate and have pneumonia and new symptoms at end of life. So it's really just on demand and led by what the patient desires, and just reassuring the family that he is not suffering because he's not taking food or drink at this point. It's what we expect, that he wouldn't be taking food and drink at this point. So another common concern addressed by Dr. Hunter, so a bit of repetition here, is whether Saiful can hear. And as Dr. Hunter said, we advise people that we're not sure, but we encourage families to assume that hearing is intact, and encourage family to speak with their loved one. And family may ask, or they may not, what to expect next. And whether they ask or don't ask, it's really good practice to let family know what's coming, what's likely coming next, because it might be the first time they've been in this situation, and they really need to know what is sort of normal in the dying process, so that they do not think something different should be happening and seek medical care and lose the time of being at the bedside and creating a comfortable space by thinking that it's an emergency situation. As Dr. Hunter said, this is not an emergency. Dying is not an emergency situation for patients where you're expecting dying. So what we would say to Seifel's family is that we anticipate that moving forward, he will be sleeping most of the time. The time he wakes up will become shorter and further apart. Eventually, he won't wake up and respond to voice anymore. And then we might see, as Dr. Hunter explained, changes in the breathing pattern. And we often start to see pauses in the breathing, so periods of apnea, which can last for a few seconds. And then the person will start breathing again. So we get irregular breathing pattern. And this is very normal during dying. And if we tell the family that, it can be very reassuring for them, because when they see a pause in the breathing, they think, oh, are they going to take another breath? And we can explain to them, actually, usually this irregular breathing pattern will then become regular and shallower breathing, and eventually the breathing would fade out. So having those gaps in breathing is a normal part of the dying process. So that's the end of this case. And really, it was just to illustrate again and reinforce the points that you've heard in the earlier lectures. So please do share any questions or comments you may have. Thank you.
Thanks,
Has anyone
Dr.
seen any other breathing patterns? Maybe just thinking about something. If you've seen somebody die, what did their breathing look like when they were at the very last few minutes of their life?
যারা মৃত্যু পথযাত্রী বা মারা যাচ্ছেন এরকম রোগী দেখেছেন, তারা যদি একটু লিখেন যে ব্রিদিং প্যাটার্নটা কিরকম ছিল। আমরা এখানে আজকের কেস প্রেজেন্টেশনে এক ধরনের ব্রিদিং প্যাটার্ন নিয়ে কথা বলেছি, আপনারা কিরকম দেখেছেন একটু যদি জানান। আপনারা চ্যাট বক্সে লিখতে পারেন অথবা নিজে কথা বলতে পারেন। I don't know why participants are so quiet today. I'm pretty sure it's not that cold in Bangladesh at the moment, or you're feeling sleepy around 9 p.m., 9:30 p.m. That's not the reason.
I just wanted to make a comment. I think that end of life is very difficult. And I think that as we do palliative care more often, we will learn. The first few patients that you help and families that you help at the end of life, you may be nervous, or it can be really challenging and you might make mistakes. But I think to have confidence that as you walk alongside these families, you will get better at it. And I think that when we do palliative care, of course, not every single patient is going to be dying at the same time. So you also will have time to implement what Dr. Hunter and Laila are teaching you in these moments. And I think it's the best time to implement those things when the patients are dying. So I think it's really helpful to remember that it might be your first time that you are with a patient, but it probably will be very memorable. So take the situations as they come. Try and put as much information as you can into caring for the patients, and with each patient and family that you help, because I think at the end of the day, we are helping our patients, even when they're dying, you will get better at it and you will be more confident, and you will start teaching the nurses and doctors around you how to take care of these patients as you do it more. I know these topics are really challenging, especially when we are talking about the end of life. It's also very spiritual. It is very difficult. But I think, yeah, as you take each patient and each day, even as someone is dying, you will get better and better at it. And I think that just to prove all the faculty that are here and the fact that so many people continue to come to the session, that people are wanting to learn how to do it better. So I think that's really, I'm really encouraged. I'm really proud of you all.
In the chat box, we could see Samiul Islam written that severe airflow obstruction and shallow breathing in response to the previous question. And Saiduzaman, he wrote, one of my colleagues raised a question that when to start end-of-life care. Dr. Hunter, please. Or any other faculty member.
I can answer that
sorry,
one. Oh, go ahead, Hunter.
No, sorry. I was just trying to get my internet to work. Can you hear me okay? Great, thank you. Well, that's a very good question. I don't have a specific answer about when to start end-of-life care specifically. I think that it depends on the individual situation, the patient and the family, and the discussions that have been ongoing. In terms of, there's no specific day or time or indication to start talking about end-of-life care or to proceed with end-of-life care. I think that at the end of my short talk today, I talked a little bit about making sure that our care goals are aligned with what is happening medically and physiologically with the patient, and what the patient's understanding or the family's understanding of what's happening are. So it's a process. It's not a specific time that starts. But hopefully, if we have been doing good ongoing work with the patient and the family, we have been developing a relationship with them, that this is part of the conversations that we're having along the way. I realize that's a little bit of a vague answer, but I think that that's the best I can offer at the moment. I can certainly ask Dr. Catherine, Dr. Tasneem, Dr. Megan, anyone else, Aaron, anyone else to chime in as well.
Maybe does Laila want to say anything about that? Because, you know, having seen a lot of patients get end-of-life care at PCU, maybe there is a bit of a protocol. Like, what do you guys do?
Yes, end-of-life care, actually, I am on night duty today, and last night, one of my patients died. So, end-of-life care, we can say that when his patient is gradually falling, like patient is less urine output or less communicating with us or less sometimes restlessness, and sometimes at the early stage patient is more sleeping or more withholding or withdrawing of the circumstances or environment or communicating with family, and sometimes we see patients restless and sometimes delirious state, and sometimes as not. So I agree with Irene that it is completely that our clinical practice allow us to understand or the thing that the patient is approaching the gate, and the more time pass on, that the moment of that the patient died, their patient gets pain and air, hunger, respiration, and there may be some other like pain, restlessness. I see most of my patients at the end of life. Yeah, this is vary from one patient to another.
There's some, it's Jillian, hi, there's some good questions in the chat now about shortness of breath and daily nutrition. Do you want me to, I can respond. So if the patient is suffering from shortness of breath, will be the best approach, as Dr. Catherine said, in this morphine, oral or subcutaneously, if you can do it, is the best treatment for severe shortness of breath at the end of life. If it's not that severe, you can do other things like get a fan, reposition those sorts of things. As we talked about in the dyspnea talk, the best approach to ensure daily nutrition when somebody's at the end of life and is dying, they're not hungry. You don't need to ensure daily nutrition, but what you do need to ensure is you keep their mouth moist, little sips. If they do want to eat or drink a little bit, their favorite foods, whatever they like. But this is not the time where you're going to be putting in, giving them supplemental hydration if the person is actively dying. Thank you for the question.
I think the other thing I wanted to comment on is when to start end of life. I think it's really important. I know that in the refugee camps, it can be very difficult to feel like you're part of a team related to palliative care because you are very few that are knowledgeable or trained on palliative care. But I think that it isn't necessarily a decision one person makes. So just regularly updating yourself and the team on what's going on with the patient can help make those decisions if someone is actively dying, or like Dr. Hunter was saying, in that imminent stage. So if just one person is trying to say, okay, they're dying, it's good to get other people's opinion on what's going on, or the treating doctor, so everyone can be on the same page to know how to best treat them. And in terms of the best person to ask, if the patient is not responding, I think at end of life, it can be really difficult when patients are not responding, but their next of kin, or the person that is able to make decisions on behalf of the patient. So oftentimes that's a spouse or a child. And we really encourage you to have those kinds of discussions before, like several weeks or months before, if you know someone has a terminal illness or is very ill, to decide who's going to make decisions for them when they no longer can. Because in the moment, at the end of life, it's very difficult and it can be very stressful for families to find the right person to make those decisions.
Thanks, Erin. And Jillian wrote, the person who is spending the most time with the patient usually knows best what is happening. কি ঘটছে সেটা রোগীর পাশে যিনি থাকেন অথবা রোগীর সেবা যিনি দিচ্ছেন তিনি হয়তো সবচেয়ে ভালো বলতে পারবেন। Megan, you wrote something in response to Dr. Mridul's question about the nutrition, providing nutrition on daily basis to the end-of-life care patient. Could you please explain that one?
Yeah, I think it's been explained a little bit already, but just to remember for ourselves that it's only, the nutrition is just for comfort, you know, so that the patient doesn't feel hungry and whatever they want to eat, they can eat. But the amount of food they take is not going to change how long they live, right? Because they have advanced illness and that's what's going to make them die. And the nutrition is just there as something, if they like it, they can do it. If they feel comfortable, they can eat, but they don't have to force themselves to eat, and eating more won't make them live longer. So I just wanted to emphasize on that point, because we can counsel the family about that too, because the family might be saying he has to eat. We can say, you know what, he should just eat what he wants. And I've had 2 patients choke at the end of life because their spouse was like, you have to eat. And the patient couldn't eat very much and the patient choked, and it's very traumatic. So really important to just tell the family, okay, just give him small amounts, don't force it, and help the family to understand that that's not going to change how long the patient lives for. Do you want to translate that?
Yes. Thanks, Dr. Megan. ডক্টর মেগান যেটি বলছেন সেটা হচ্ছে এরকম একটি পর্যায়ে আমরা যদি একজন রোগীকে ফোর্স করে খাওয়ানোর চেষ্টা করি অথবা আর্টিফিশিয়ালি খাবার দেওয়ার চেষ্টা করি, আমাদেরকে বুঝতে হবে যে এটা এখন আর তাকে বেশি দিন বেঁচে থাকার জন্য, ভালো বোধ করার জন্য বা শক্তি ফিরে পাওয়ার জন্য, নিজে কিছু করার জন্য আসলে সেই ধরনের খাবার দিয়ে আসলে কাজ করানো যাবে না, যে এরকম খাবারের তার একটা চাহিদা রয়েছে। মেগান একটি এক্সাম্পল দিয়েছেন যে একজন রোগীর ক্ষেত্রে হয়েছিল যে তার ওয়াইফ তাকে ফোর্স করছিল খাওয়ার জন্য। আপনারা দেখতে পাচ্ছেন, আমি লিখেছি যে খাবারের ক্ষেত্রে যদি আপনি জোর করেন, এই আর্টিফিশিয়াল খাবারটা দেওয়ার চেষ্টা করেন, এটা বরঞ্চ তাকে খারাপের দিকে ঠেলে দিতে পারে। ডক্টর ক্যাথরিন কমেন্ট করেছেন যে এখান থেকে তার শ্বাসকষ্ট আরো বেড়ে যেতে পারে, পেরিফেরাল এডেমা পর্যন্ত হতে পারে আইভি ফ্লুইড দেওয়ার জন্য। কারণ আপনি যখন ওই অবস্থায় তাকে ফ্লুইডটা দিচ্ছেন, আপনি শুধুমাত্র নিউট্রিশনের কথা চিন্তা করে দিচ্ছেন, কিন্তু এটার সাথে সাথে কিছু সাইড ইফেক্টও চলে আসতেছে, এবং শরীর যে অবস্থাটাতে থাকে ওই সময় এই আইভি ফ্লুইডটা নেওয়ার মতন অবস্থায় সে থাকে না। তবে আমরা যারা রোগীর সেবা দিচ্ছি তাদের ক্ষেত্রে, অথবা রোগীর বাড়িতে যারা সেবা দিচ্ছেন তাদের ক্ষেত্রে একটা বিষয় হয় যে একটা ইমোশনাল ব্যাপার চলে আসে, যে খাবার দেব না, খাবার না দিয়ে রোগীকে রাখবো, বা খাবার দিচ্ছি না, এটা শুনতে কিরকম মনে হচ্ছে। কিন্তু আমাদের সবসময়, আমরা যিনি কেয়ার গিভার আছেন অথবা আমাদের নিজেদের ক্ষেত্রে এই জিনিসটা বুঝতে হবে যে আমরা কতদিন সে বেঁচে থাকবে এরকম একটা আশা করছি, এবং এইখানটায় খাবার দিলে তার কি কি ভালো দিক হবে, খাবার না দিলে কি কি ভালো দিক আসতে পারে, দুটোই হতে পারে, এটা রোগী ভেদে নির্ভর করছে। কিন্তু আমাদের কাজ হবে নিজেরা বুঝতে পারা যে কোনটি করা প্রয়োজন, এবং অবশ্যই নিজের সাথে সাথে অন্য যিনি কেয়ার দিচ্ছেন এই রোগীর জন্য তাকে বোঝানো। Now we will go for the Bangla translation. Today, Laila Firdaus Appa will do the Bangla translation. Over to you.
আজকে দুটো টপিক নিয়ে আলোচনা হয়েছে। একটি হচ্ছে যে জীবনের অন্তিম মুহূর্তে নিরাময় অযোগ্য রোগীদের সেবা, এবং কি নার্সিং বিষয়সমূহ নিয়ে। তো জীবনের শেষ অন্তিম সময়ে যে সেবাটা দেওয়া হয় সেটা যে যদি আমরা এমন জীবনের শেষ সময়টা কখন আমরা উপস্থিত হয়েছে বুঝতে পারবো। তো এটার কয়েকটা বিষয় আলোচনা হচ্ছে যে প্রথম দিকে যখন আমরা বুঝতে পারি যে একটা মানুষ যখন শয্যাশায়ী হয়ে যায়, কিংবা তার মুখের খাবার গ্রহণের পরিমাণ কমতে থাকে, কিংবা তার ঘুমের একটু পরিবর্তন হয়, কিংবা অনেক সময় উনি অস্থিরতা অনুভব করেন, কিংবা একটু বিভ্রান্ত হয়ে যান, তারপরে ধীরে ধীরে ওনার অবস্থা একটু খারাপের দিকে যেতে থাকে, এবং শেষের দিকে যখন একদম উপস্থিত হয় জীবনের অন্তিম মুহূর্ত, অনেক সময় দেখা যায় যে উনি না উনি একটা নয়েজি একটা ব্রিদিং হয়, একটা পেশেন্ট একটা দেখা যায় যে অনেক জ্বর আসতে পারে, কিংবা উনি একটু অস্থির অনুভব করতে পারেন। তো এই ধরনের জিনিসগুলো আসলে হতে পারে। তারপর যেটা আলোচনা হয়েছে যে এই এই সময়গুলোতে আসলে আমরা কোনটা বেশি গুরুত্বপূর্ণ। আমাদের কেউ যদি খুব অসুস্থ থাকেন, কিংবা কোনো ব্যথার মধ্যে থাকেন, এবং যে কোন উপসর্গগুলো ওনার আছে, এগুলো আসলে তখন আমাদের আইডেন্টিফাই করাটা গুরুত্বপূর্ণ। যেমন উনি কি ব্যথা পাচ্ছেন কিনা, নাকি ওনার বমি হচ্ছে, কোষ্ঠকাঠিন্য হচ্ছে, মানে শ্বাসকষ্ট হচ্ছে, কোনটা সেই অনুযায়ী প্রতিটা একটা পরিকল্পনা করতে হবে, পরিবারের সাথে বসে তারপর আমাদের আলোচনা করতে হবে। জীবনের শেষ সময়গুলোতে এই সবাই মিলে দলগতভাবে যে একটা যোগাযোগ, এবং কি পরিবারকে আমরা সাপোর্ট করা এই ক্রিটিক্যাল সময়টাতে, এটা খুব গুরুত্বপূর্ণ। তাতে রোগীর একটু আরামের ব্যবস্থা করা যায়। তবে এটার ক্ষেত্রে যে আমাদের একটা নির্দিষ্ট একটা উদ্দেশ্য বা লক্ষ্য ঠিক করে নিতে হবে, যে আমাদের ওই ওষুধগুলো আমাদের বন্ধ করে দিতে হবে যেটা কিনা রোগীর আরামের সাথে সম্পৃক্ত না সরাসরি। সেগুলো অনর্থক ওষুধগুলো আমাদের বন্ধ করে দিয়ে শুধুমাত্র রোগীর আরামের দিকে আমাদের চিন্তা করতে হবে। যে কোনো ধরনের ইন্টারভেনশন এগুলো আমরা বন্ধ করে দিতে পারি জীবনের একদম শেষ সময় যখন উপস্থিত হবে তখন। আমরা রোগীর পরিবারের সাথে সরাসরি আলোচনা করব যে আসলে রোগীর সাথে কি হতে যাচ্ছে, যে আসলে উনি এখন মারা যাচ্ছেন। এটা একদম একটা আমাদের ভালো একটা কমিউনিকেশন হতে হবে। ওই সময় রোগীর মুখের যত্ন, ত্বকের যত্ন, এবং অন্যান্য যে নার্সিং বিষয়গুলো আছে এগুলোর যত্ন নিতে হবে। পরিবারকে আমরা কিভাবে আমরা আরো সাপোর্ট দিতে পারি সেটা আমরা পরিবারের সাথে বসে ঠিক করে আমরা জিজ্ঞেস করতে পারি। এই বিষয়গুলো হতে পারে। এখানে আমাদের মনে রাখতে হবে যে কিছু শারীরিক, মানসিক, সামাজিক এবং কি আধ্যাত্মিক বিষয়সমূহ থাকে যে রোগীর পরিবারের সাথে জীবনের শেষ সময়ে হয়তো বা ওগুলো ঠিকঠাক করা যায়। যেমন শারীরিকের যদি আমরা মনে করি যে উপসর্গগুলো নিয়ন্ত্রণ করা, রোগীর পরিবারকে শেখানো, একটা চিকিৎসার একটা প্ল্যান তৈরি করা, এগুলো হতে পারে। তারপর মানসিক যেটা হতে পারে সেটা যে ওনার মানসিক ভাবে উনি কতটুকু হচ্ছে উনি ডিস্ট্রেসের মধ্যে দিয়ে আছেন, পরিবারের ডিস্ট্রেস কিংবা মারা যাওয়ার পরে যে একটা সাপোর্ট দেওয়ার প্রয়োজন হবে সেটা, ডিপেন্ড সাপোর্ট। সামাজিকভাবে যেটা হচ্ছে পরিবারকে আমরা কিভাবে, এটা কি একক কোনো পরিবার না যৌথ পরিবার, তাদের কি ধরনের সহায়তা প্রয়োজন, ওনার চিকিৎসা, আশেপাশের মানুষজন কিংবা টাকা পয়সার কোনো আর্থিক সমস্যা হচ্ছে কিনা, মারা যাওয়ার পরে ওনারা প্ল্যান করছেন কিনা, কিভাবে কি করবেন। আধ্যাত্মিক বিষয়সমূহ নিয়ে আলোচনা করতে পারি, যে রোগী কিংবা তার পরিবার কোনো নির্দিষ্ট কোনো কিছু কোনো ধর্মে বিশ্বাসী কিনা, যদি হয়ে থাকেন তাদের রোগীকে কোনো বিষয়ে এটা কোনো তাকে কোনো ধরনের কোনো আর কি সমস্যার সৃষ্টি করছে কিনা কিংবা ডিস্ট্রেসের সমস্যা করছে কিনা, এখানে কোনো আমাদের কোনো ধার্মিক কোনো ব্যক্তিত্বকে নিয়ে আসলে রোগীর সাথে কথা বলে কি রোগীর কোনো উপকার হবে কিনা, এই বিষয়গুলো আমরা হচ্ছে আলোচনা করতে পারি। তারপর আরেকটা আলোচনা হয়েছে যে আপনার নার্সিং বিষয়সমূহ নিয়ে। তো নার্সিং বিষয়সমূহ নিয়ে যখন আলোচনা হয়েছে, এটা নিয়ে আলোচনা হয়েছে যে কিভাবে একজন রোগীকে শেষ সময়ে শয্যাশায়ী রোগীকে পরিষ্কার পরিচ্ছন্ন রাখা যাবে, গোসল করানো, এটা নিয়ে আলোচনা হলো। তারপর হচ্ছে ওনাকে আমরা স্কিন কেয়ারটা কিভাবে দিব, তারপর আমরা হচ্ছে ক্ষত হয়ে গেলে ক্ষত পরিচর্যা কিভাবে করব, এখানে আলোচনা হয়েছে যে নর্মাল স্যালাইন দিয়ে আমাদের হচ্ছে পরিষ্কার করতে হবে। তারপর হচ্ছে যে সমস্যাটা হবে, ব্যথা হলে ব্যথার ওষুধ আগে দিয়ে নিতে হবে, দুর্গন্ধ হলে আমরা যে বিষয়গুলো নিয়ে আলোচনা করলাম যে মেট্রোনিডাজোল আমরা ইউজ করব, ট্যাবলেটটা আমরা ক্রাশ করে, তারপর হচ্ছে ব্লিডিং হলে আমরা ট্রানিজেমিক অ্যাসিডটা ব্যবহার করব, সুপারফেট ট্যাবলেট ক্রাশ করে ব্যবহার করতে পারি। এগুলো আলোচনা হলো। তো এইগুলো নিয়ে মোটামুটি আলোচনা হয়েছে। ধন্যবাদ সবাইকে।
Thank you, Laila. Tasneem, you're back. Go ahead.
Thanks, Laila, Atulapa. You have touched almost everything that we discussed today, and definitely the lecture where we talked about the personal hygiene and how to move the patient, it was really important for all of us. Over to you, Dr. Catherine, to announce the issue of attendance that was asked by Said earlier.
Thank you, Tasneem. And Said, I ask you to just translate into Bangla afterwards as well. So we have shared here a form, an online form for you just to mark your attendance for each of the core sessions. So there were 7 core sessions for this course that it's mandatory to attend to get the course certificate at the end of this course. So if you have missed one of the sessions, that's no problem. We just ask you to mark that you've watched the recording of the session so that we can see that you have followed each of the core 7 sessions for the module. So please do complete this form, and we'll send it by email as well for those who aren't in the session today. Okay, thank you.
Thank you, Dr. Catherine. Thanks for all other faculty members for your nice cooperation and making this opportunity to learn. So thanks again. যেটা বলা হচ্ছিল আপনাদেরকে সেটা হচ্ছে আগে আমি যেটা করতাম স্ক্রিনশট নিয়ে আপনাদের অ্যাটেন্ডেন্স গুলি ট্র্যাক করতাম। তো এর মধ্য থেকে দেখা যেত যে কিছু এদিক সেদিক হতো। তো এই জন্য এখন নতুন করে যেটা করেছি সেটা হচ্ছে যে গুগল ফর্ম একটা আমরা করেছি, সেইটাতে আপনি আপনার অ্যাটেন্ডেন্সটা হচ্ছে যে দিয়ে দিলেন। আর খুবই গুরুত্বপূর্ণ বিষয় যেটা সেটা হচ্ছে আপনি যদি কোনো সেশনে জয়েন না করে থাকেন সেক্ষেত্রে এখানে ইউটিউবের লিঙ্কটা দেওয়া আছে, যেখানে হচ্ছে যে সবগুলি সেশন ফ্রি লোডেড আছে, সেখানে আপনারা দেখতে পারবেন। আর একটা হচ্ছে যে এটা হচ্ছে যে আপনাদের মানে সৎ আর কি আপনারা সৎভাবে এটা ফিল আপ করবেন বলে আমরা আশা করছি। আর যেটা সেটা হচ্ছে যে এইটার উপর ভিত্তি করে আপনারা হচ্ছে যে আমরা ডিসিশন নিব যে কারা হচ্ছে যে সার্টিফিকেট পাবেন। তো আরেকটা জিনিস যেটা হচ্ছে ইউটিউবে কিন্তু আপনারা যদি ভিডিওগুলো ভিউ করেন তাহলে আমরা কিন্তু দেখতে পাই যে কতজন ভিউ করেছে। তো এইটাও একটা জিনিস। সব মিলিয়ে এই নিয়ে যদি আপনাদের কোনো প্রশ্ন থাকে আমি হোয়াটসঅ্যাপ গ্রুপে আছি, তাছাড়াও আপনারা আমাকে ইমেল করতে পারেন অথবা ডিরেক্ট কল করতে পারেন আপনাদের যে কোনো কোয়েরিজ থাকলে। সবাইকে অনেক অনেক ধন্যবাদ, সবাই ভালো থাকবেন। Over to you, Dr. Catherine.
Thank you, Saeed. So I don't really want to, thank you everybody for your participation on this course. It's been a really excellent course. I don't really want to say goodbye yet because we do have another session next week. So next week we have an open session. So it's open for all of the courses. And Anne will be the speaker. She will be doing a session on psychological distress and trauma-informed care. So it should be a really good session. So we encourage you to come along next week. But this is the final module of the core course, as I've said. Following on from this course, which will end next week, we will have ongoing what we call open or mentoring sessions. So we usually have been running these every 3 or 4 weeks, where we just encourage you to come back to us. We will give you topics and try to update and keep updated your knowledge on palliative care. Again, we encourage you to put into practice all of the things we hope you've learned during this course, and encourage you to come to these sessions where we have faculty, international faculty and Bangladeshi faculty who are experts within their field in palliative care, and they can really help you with any difficulties or challenges you're facing in your area of work. So please do continue to connect with us and continue to use these sessions to help you with your practice. Megan, do you want to say something about the end of course survey?
Yes, I want to say, please fill the survey for us, which is separate from the attendance. I've put it in the chat a couple times and in the WhatsApp group. It really helps us if we can have your feedback on the course and just know what did you learn and how did you learn from the course. And like Catherine said, we have the ongoing mentoring sessions, which continue. So it's not a full goodbye from all of us. And also we will have another pediatric palliative care course in October. And we usually run this adult palliative care course about 3 times a year. So if you want to join it again, just to catch up or anything you missed or just to listen again and join, then you're most welcome. We'll be posting the information about the next course in the WhatsApp group. But there is a pediatric course that's going to start October 8th and run for 6 sessions. It's the same course that we already ran in Bangla, okay, that just finished. This one is international edition, so it's fully in English, just so you know. We will run another Bangla one after the English one, but we're going to alternate Bangla, PPC, pediatric course, English palliative care course, just like that for the course, the pediatric course. Yeah, and if you can just switch over to the Universal Echo group, we like to close the WhatsApp group for this batch, and then you can just join into all the participants who've joined any of our Echo programs, any of our courses, so that we don't have to have multiple WhatsApp groups. So we'll probably close the batch 3 group, but we'll post a link to join the combined WhatsApp group with all the palliative care trained providers in Bangladesh. So thank you, everybody.
আচ্ছা, দুজনের কথারই সারমর্ম সেটা হচ্ছে যে আমরা এখনই আপনাদেরকে বিদায় বলছি না, এটা আসলে শেষও নয়, কারণ হচ্ছে যে আমাদের আগামী যে সপ্তাহ আসছে সেই সপ্তাহে হচ্ছে আমাদের মেন্টরিং সেশন থাকবে, সেখানে সবাই জয়েন করতে পারবে। কিন্তু ব্যাচ 3 এর জন্য এটাই হচ্ছে যে আমাদের লাস্ট সেশন, আর সেজন্য হচ্ছে যে দয়া করে আপনারা সার্ভেটা ফিল আপ করবেন। এটা একটা ভলান্টিয়ারিং একটা পার্ট বলতে পারেন, এটা হচ্ছে কিছুটা আপনাদের কাছ থেকে ফিডব্যাক কেমন ছিল, কেমন হলো, বা পরে এটাকে আরো কিভাবে ভালো করা যায়। তো এইটা হচ্ছে আমাদের পক্ষ থেকে আপনাদের প্রতি এটুকু চাওয়া বলতে পারি যে আপনারা সার্ভেটা কমপ্লিট করবেন। আর ফাইনালি যেটা বললো সেটা হচ্ছে যে পিসি ইকো নামে একটা হোয়াটসঅ্যাপ গ্রুপ আছে, যেখানে হচ্ছে যে আমরা সকল প্রকার আপডেট হচ্ছে শেয়ার করে থাকি। সেটা ছাড়াও ক্লিনিক্যাল ডিসকাশন সেখানে হয়ে থাকে। আপনারা যদি কোনো প্রকারের প্যালিয়েটিভ কেয়ারের পেশেন্ট পেয়ে থাকেন, সেক্ষেত্রে আপনারা সিনারিওটা ওই গ্রুপে আপনারা পোস্ট করতে পারেন। যেহেতু এখানে ইন্টারন্যাশনাল এক্সপার্টরা, ন্যাশনাল এক্সপার্টরা আছে, তারা সেক্ষেত্রে আপনাদের এই যে সিনারিও গুলো দেখে আপনাদেরকে কিছু মতামত দিতে পারে, কিছু ভালো সাজেশন দিতে পারে। তো এই হচ্ছে যে ডক্টর মেগান এবং ডক্টর ক্যাথরিনের কথা সারমর্ম। আমি so I would like to invite other faculty member if you wish to share something. Yes, please, you can go ahead.
Said, thanks for the Bangla translation, and you have already talked about very important issue, and I will discuss very shortly in Bangla with this. Said আপনাদেরকে জানিয়েছেন যে ইউটিউবে আমরা যে ভিডিওগুলো দিচ্ছি সেগুলো আপনারা দেখার পর আপনারা দেখেছেন এটা লিখে দিলেই হবে, এবং একই সাথে আমরা কতগুলো ভিউ হয়েছে সেটাও দেখতে পাই। আমি শুধুমাত্র আমার একটা বাস্তব অভিজ্ঞতা বলবো যে আমরা একটা সেশন শুরু হওয়ার আগে একটা লিংক শেয়ার করেছিলাম, এবং আমি দেখেছি যে সেই ইউটিউব ভিডিওটি 16টি ভিউ হয়েছে, যেখানে আমার নিজেরই 6টা ভিউ ছিল। আমি মানছি যে আমি খুব আমার একটু পড়তে সময় লাগে, আমার 6টা ভিউ ছিল ঠিক আছে, কিন্তু সেদিন আমরা পার্টিসিপেন্ট ছিলাম প্রায় 36 জন। সুতরাং আমরা দেখেছি বা না দেখেই চলে এসেছি সেশনটাতে, এটা কিন্তু আমাদের জন্য হেল্পফুল না। এবং শুধুমাত্র অ্যাটেন্ডেন্সের জন্য যদি আমরা লিখে দিই যে ডান, ইউটিউব ভিডিও দেখা হয়ে গেছে, সেটাও আসলে কোনো দিক থেকে কাম্য না। আপনারা যারা বাংলা ভাষাভাষী আছেন সবাই যদি এই বিষয়টা একটু নজরে নেন, আমরা খুবই, আমার মনে হয় আমরা আরো ভালোভাবে শিখতে পারবো। I guess we are done for today. I'm closing the session now, and hopefully we'll see you next week. Thanks, everyone.
Thanks all. Bye now.